Hi guys, good evening. कैसे हैं आप लोग? My name is Dr. Kunal and I'm welcoming you all for this live doubt session of pathology on behalf of the entire family of MIST. Now, I had got some questions on the Google Forms which you have sent, and I would be happy to take any of the questions which you send me while during this session. So, your exam is there on 12th of December. So to all the FMGs, I mean, it's very important to work hard in these 40 days which you have left for the exam, and we hope and we believe that each one of you, whoever is going to be appearing on 12th of December, would be working really very hard to crack this exam, and we wish you good luck. So I'll start with the first doubt which I got. The first doubt was regarding the complement system. Now, in the complement system, as I have told you that this is something which we have inside our blood, and these protein molecules, they are inactive molecules, more than 20 in number, and we are numbering them from C1 to C9. Now, to have their functioning properly, we need to activate them, and for activation we have got three pathways by which we can activate. But then the number one is classical and alternate. So these are the two spaces from where you can get the questions. Now, classical pathway, see what you have to learn when you are going for the exam, that whenever there would be a classical activation, it would be through antigen antibody complex, and whenever there would be an alternate activation, it would be with the help of factor B. What kind of questions they can ask you? Whenever a complement system is activating from from this C1 directly, so that means the classical pathway has activated this complement system. Whereas if the complement system is getting activated directly at the level of C3, that means skipping of the step of C1, C2 and C4, then that means it's a alternate activation which is happening. Now, what is the essence of this complement system activation? That is what we have to understand. The essence is, these three things, that whenever a complement system is getting activated, it is leading to the formation of these three molecules. Now, number one molecule happens to be C3b. Now, this is a molecule which is needed for opsonization, as we know, and opsonization is basically, a covering. So whenever our defense molecules cannot see what they have to basically kill, this C3b molecule comes and covers that particular thing, and then our complement molecules or our our WBCs, they can go and kill that particular thing. So opsonization is one function. Chemoattraction, when you have to call your WBCs towards the site of injury, so then you need some anaphylotoxins, some molecules which can attract those WBCs. So for chemoattraction, we need this complement system, and cell lysis with the help of MAC. Now this MAC is membrane attack complex, and it is this particular product which you are seeing, C5b6789. Okay, so this is what the complement system is. Second query which I got was regarding the just give me 1 second. Yeah, it was regarding the irreversible injury, and in the irreversible injury, you have asked that why myelin figures cannot be a feature of irreversible injury. Now see, as we have written, these are the pictures which I have taken directly from the notes which we have written in the classes. So the students which have taken the classes with me, then in this myelin figures, as I have mentioned, that myelin figures would be seen in irreversible injury majorly, predominantly, but they can also be seen in reversible injury. Whereas if we talk about these particularly amorphous densities, now these are what? These are basically calcium deposits inside the mitochondria. So they will only be seen with irreversible injury, because the major ion which is responsible for irreversible injury, that means cell death inside a cell, that's going to be calcium. So amorphous densities, they are only and only seen with irreversible injury. That is why between amorphous densities and the myelin figures, amorphous densities becomes the better choice to answer. Okay, myelin figures would be seen, but they are not only and only seen in irreversible. They can also be a part of reversible injury. That is why amorphous densities is a better choice. Coming to the next question. Now it was, there was some confusion in the graft rejection somebody had. Now in this, hi Mohan, hi Rajendra, hi Nikhil. Yeah, we'll talk about the tips of the neoplasia too. And yeah. So after even the live session, you can see this. These are some doubts which people have sent me. So I'm taking it here. So yeah. So regarding the graft rejection, see, there are three kinds of graft rejection which we have, and there are four types of grafts which we have. Now, regarding this has also been an FMGE question quite many of times. So iso means when you are having a graft between the identical twins. Auto means when it is between the same person. Allo in the same species, that means human to human. And xeno, it is between different species, like we are doing the wall replacement. So from a cow we are taking the material from which we are making a wall and we are putting in the human. So it's xeno, different species. Okay, so these four types of graft. Regarding the graft rejection, we've got three kinds of graft rejection. By the name only we can understand, it's hyperacute or chronic. Now hyperacute means which is very fast. Acute, already it is fast, but then hyperacute is very fast, and chronic when it is late. Now anything which is after 6 months, it's chronic. Anything which is between minutes to hours, it's hyperacute. And anything which is in between of these two, that's acute. Now why they are happening? See, we have studied the hypersensitivity. This is hypersensitivity which a person's body is doing against the graft. When you're putting a graft, the recipient's body is becoming hypersensitive against it. So, let's say in the hypersensitivity reaction, we have studied four types of hypersensitivity reaction. And if you remember, the type 4 hypersensitivity reaction, uska naam hi delayed hai. Delayed hypersensitivity, T cell mediated. So, ये जो chronic है, which is more than 6 months, because it is happening late. So it's due to type 4 hypersensitivity predominantly. When we are talking about hyperacute means suddenly. That means you are already prepared. The body was already prepared to reject. It doesn't matter whether the thing is right or wrong. It's like the body already has the antibodies which are going to kill whatever you are going to give to it. So antibody mediated hypersensitivity is type 2. So hyperacute is type 2 hypersensitivity. Whereas when we talk about the acute one, it is in between. So it is type 2 and type 4 both, but predominantly it is type 2. So three types of graft rejection: hyperacute, acute and chronic. And when we are talking about hyperacute, it is type 2. Acute, it is predominantly type 2 but could be type 4 also, and chronic is type 4 only. Then the next question which was there regarding the genomic imprinting. Now genomic imprinting, again a very important thing for the exam. Now what exactly is this? It's silencing of a gene. Mind you, it's not that the gene is not present. The gene is there, but it is not working. It's silenced. Now, why this silencing is happening? Because of a process called as epigenetics. Okay, it is happening on chromosome number 15, as you all must be knowing, and on this particular chromosome, due to epigenetics, either a maternal gene can become silenced or a paternal gene can become silenced. Now, till this point when the silencing is happening, not a problem, because if let's say a maternal gene is silenced, so at that particular time the paternal gene is working. And if let's say due to epigenetics a paternal gene is silenced, so a maternal gene is working here. So it's not a problem. But then whatever the active gene we have, if that active gene is let's say mutated, and in mutation there is a deletion which has happened. So due to epigenetics, out of the mother and father, only one gene was active, and let's say there's a problem with that active gene. So obviously now there is nothing to save the child, so there would be a disease. So if there is a maternal deletion, deletion is the most common cause, okay, of the disease. So if there is a maternal deletion which is happening, so mummies are angel, so it would be Angelman syndrome. And if a paternal gene is deleted, okay, so P for paternal, P for Prader-Willi. This is how you can learn. So learn करना है किस पे? Deletion के basis पे. Maternal deletion ये नहीं कि maternal is Angelman. No, maternal deletion is Angelman, and paternal deletion is Prader-Willi. Then they might ask you the gene. So it is UBE3A. इसमें A आता है ना बेटा? So A for Angelman. So with Angelman you have this gene, and for Prader-Willi you have the SNP gene, P wala. You have the SNP gene with Prader-Willi. And then you can also understand this by a concept that let's say mother is not working, let's say mother is out of station, so who's going to take the double responsibility? Papa is going to take the double responsibility. So whenever we are talking about a maternal deletion, we can also relate to as paternal duplication or disomy. So if they're asking you about a paternal disomy, will lead to which disease? So paternal disomy, don't learn it with P for paternal, P for Prader-Willi. No, It's not deletion, it's disomy. So when we're talking about disomy, why would father take double responsibility when the mother's gene is deleted, right? When the mother is not there. So deletion के साथ याद रखना है आपको. You have to learn it with deletion. Maternal deletion equals to paternal duplication. So both of these will lead to Angelman, and both of these, paternal deletion or maternal duplication or disomy, would lead to Prader-Willi. And one more thing, I mean, these Angelman syndrome people, they're called as, happy puppets, mentally retarded, obese, and inappropriate laughter these patients have. Okay, so this is your genomic imprinting, the question somebody has asked me. Then, what is the most common cause of mental retardation, you have asked? See, the most common genetic cause of mental retardation happens to be Down syndrome. We have written, these are again my class notes which we have written. Overall most common cause, Down syndrome, but the second most is Fragile X. So never get confused in this. Fragile X is second most common, and the most common happens to be your Down syndrome. And with the Fragile X syndrome, they can ask you that what is the repeat which is going to which will be repeated in a patient, that is the CGG repeats. Now, do we have it normally? Yes, we have CGG repeats in us normally. So, how many? 5 to 49. This much repeat we can have in ourselves. 50 to 199, if the repeats are in this range, then it means a pre-mutated state. The patient is not suffering from a disease, but then the patient is also not normal. And when we have more than equal to 200 repeats, okay, then it leads to Fragile X syndrome. And with Fragile X syndrome, always remember the word macroorchidism. So the most characteristic feature of a person suffering from Fragile X syndrome is macroorchidism. And this is the second most common genetic cause of mental retardation, and the gene which is getting retarded, which is getting mutated in these individuals, that is going to be FMR, familial mental retardation. So obviously the gene is the FMR, so you can understand, it will lead to mental retardation. But overall, if somebody asks you the most common genetic cause of mental retardation, always and always go for Down syndrome. So I think your confusion ends here. Then, there was some confusion in the LDH flip somebody had. So see, we have seen this, and you all must have studied at different places that, LDH, this enzyme normally, if we talk about LDH1 and LDH2. So LDH1, it's more in the cardiac myocytes, whereas LDH2 is, more in our, blood. So normally if a patient is not suffering from MI, you would find LDH2 more in the blood. But if let's say a patient had MI, so in the MI, because the cardiac myocytes are containing LDH1, so when the MI has happened, when the cardiac myocyte has got injured, so all that LDH1 which was inside the cardiac myocyte, it came out into the blood. So what would you find now? Because the cardiac myocytes has released LDH1 into the blood, so you will find LDH1 more as compared to LDH2. So in a normal person, you would find LDH2 more, but in MI, it would be LDH1 more as compared to 2. This is called as LDH flip. Then we'll talk about it. Dikshit, we'll talk about it, beta. Baat karenge apan. So now somebody sent me this image and told me, to explain this. Now this is HB electrophoresis image which we have, and I told you that whenever you have got this kind of an image, so you have to, this will always be in this particular sequence, and the sequence happens to be Hafsa. It will always be in this sequence. Okay, so learn this sequence number 1, and whenever they'll give you, they should give you this thing, that where we have what. And we know that, if we are talking about an adult, so we are having 3 kinds of hemoglobin inside us. We have hemoglobin A, then we have got hemoglobin A2, and we have got hemoglobin F. These are the 3 hemoglobins which we have. In the adult, the maximum proportions of hemoglobin that we would be having, that's going to be hemoglobin A. And in the fetus, it's going to be quite opposite. That's going to be hemoglobin F, right? So normally we should get this much. So if I tell you that all these, these are different patients. These are 5 different patients which we have. So, this is patient number 1. This you have patient number 2, 3, 4, and 5. So now if I ask you that what is this patient number 1? So in this patient number 1, you can very well understand, what are the hemoglobins? All the red color, it is telling you about the quantity and the presence. So wherever you have this white color, that means there is no hemoglobin present at this site. So H is not there. Normally we don't get H and we are not finding H. So it's okay. If I'm saying this is the electrophoresis chart of an adult, maximum hemoglobin will be hemoglobin A. So you are seeing a maximum area filled here. So it's fine. F is minimum in us. And hemoglobin A, as we all must be knowing, you all must be knowing that it's going to be less than 3.5%. What is the normal, finding of these? This is around 90 to 95%. A2 is around less than 3.5% and F is anywhere from 1 to 1.5%. So this is what we have normally inside us. So if you correlate this with this, maximum is hemoglobin A, you are getting hemoglobin A. Minimum is hemoglobin F, and you are getting minimum hemoglobin F here. And likewise, this hemoglobin A2, which should be less than 3.5%. So it looks that way only. So this particular patient, it's a normal person. I mean, if you do your electrophoresis, you're a normal individual, so you'll find this like this. So this thing is normal. This is absolutely normal person. Now we move on to the second one. In the second one, you can understand, hemoglobin A is getting low. Hemoglobin F has increased, but a predominant increase we are seeing is in the hemoglobin A2. This is where you have the maximum increase. Now, what is the disease which you know where you have more hemoglobin A2? More hemoglobin A2 is, a very, you all must be, knowing, you must have studied in hematology. That's your beta thalassemia. And which type of beta thalassemia? Beta minor, right? Because we have got two kinds of beta thals, beta minor and beta major. In beta minor, we have got more hemoglobin A2. So this is how it will look. Your hemoglobin A is low and your B2, hemoglobin A2 is more in beta minor. So this is a patient who is suffering from beta minor. If we come back to the third patient, again you see how much hemoglobin A, these are all are adults, okay? These are all are adults. So this person has very little hemoglobin A. Any person having so little hemoglobin A, that means it's a pathology. And which hemoglobin is more? Hemoglobin F is more. Now an adult जिसके अंदर hemoglobin F ज़्यादा है, what does that mean? That means that this patient is suffering from beta major. ठीक है? This patient is suffering from beta major. Then, this fourth one. In this, you are having not only 3 lines, but you're having 1/4 line also here. So you see which hemoglobin is this? Correlate from here. It is the hemoglobin H. Now, if we talk about hemoglobin H disease, what is it? I hope you remember the 4 types of alpha thalassemia. Now, this is a 3 gene deleted alpha thal. In a 3 gene deleted alpha thalassemia, we have got hemoglobin H disease, where you have, very less quantity of alpha 2 and beta 2. That means your adult hemoglobin, and you have a new chain coming up, which is your delta 2 and beta 2. So this is your, just learn it, hemoglobin H. Wherever they are saying hemoglobin H is present in a patient, just learn it as alpha thal, and this is 3 gene deletions. How many genes for alpha thalassemia we have? 4 genes. So 3 are deleted here, 3. Okay. So this is your alpha thal, and the last one in which you are not seeing hemoglobin H, you are even not seeing hemoglobin A at all. But there's a new hemoglobin which we have. And what is this hemoglobin? This one, this is hemoglobin S. And we all know S is sickle cell, right? So this is a patient who is suffering from actually sickle cell disease. So it's very simple that way. So if you know what you are seeing on this, and if you know the content right, if you have listened to the classes, listened to the lectures, so it is very easy to solve. Moving on to the next one, then iron profile. Now in this iron profile, the student which sent me these, we have sent you a Google form, and then you have sent us these questions. So a person specifically asked, explain about the TIBC and the transferrin saturation. See, these iron profile we are doing specifically for 2 kinds of anemias, IDA and ACD. Now what is IDA? This is iron deficiency anemia, and ACD is anemia of chronic disease. We can also do it for sideroblastic anemia, but then that is not very common. So this is the thing where you have the probability of question coming in your exam. So when we are talking about the iron deficiency anemia, in the name only we understand कि यार ये iron deficiency है. So obviously anything related to the iron will be less. What are the 4 parameters which you are seeing in iron, iron profile? First is the total iron of the body. Second is the ferritin. Now, what is this ferritin? This is actually the iron which you have stored, the reflective value of that iron, the iron which you have present in the blood, serum ferritin. TIBC, this is total iron binding capacity of what? Of transferrin. And we all know what is transferrin. Transferrin is a transport molecule for the iron in our blood. So, how many iron molecules a transferrin molecule can bind to, that is your TIBC. And T percentage, this is transferrin saturation. That means that a transferrin molecule is bound to how many iron. Like for example, a transferrin molecule, let's say for example, has got 6 sites. So out of those 6 sites on a transferrin molecule, how many sites are already filled? That is your transferrin saturation. Okay. So if you see about the iron deficiency anemia number 1, by iron deficiency है तो iron कम होगा, total iron. Obviously blood में भी iron कम होगा, तो serum ferritin will also be low. If the iron is less in the blood, that means the transferrin molecule which is rotating inside the blood to bind with the iron, that transferrin molecule is not getting the iron to bind to. So when it is not getting the iron to bind to, what will happen? The transferrin molecule will remain vacant. And if the transferrin molecule will remain vacant, obviously the capacity increases. So, you see this. Ferritin, the Fe3 plus is a molecule which sits on the transferrin molecule. Now you have Fe3 plus less. So obviously the capacity of the transferrin to bind with Fe3 plus increases. It can bind to more. So these are two inversely proportional values. Just learn this, okay? These are inversely proportional values. And transferrin saturation, obviously it decreases, right? By the sites on the transferrin molecule are empty. So obviously if they are empty, saturation is less. So this is, this is the iron profile of iron deficiency anemia. And if we compare it to anemia of chronic disease, in which the examiner confuses you, so in the anemia of chronic disease, the total iron content of the body is less. But when we talk about the serum ferritin, there is no problem with the serum ferritin. Why? Why we are saying that? See, the point is that there is no problem. What is the problem with anemia of chronic disease? In the anemia of chronic disease, the problem is in the transport of iron from the duodenum, the site of storage of the iron. From the duodenum, the iron cannot move into the blood vessel. So when iron cannot move into the blood vessel, storage iron में कोई problem नहीं है. There is no problem with the storage iron. But whatever is there inside, that is not coming into the blood. So obviously, again, when it is not coming into the blood, so TIBC would, this ferritin levels, because everything is getting stored. So stored iron is ferritin, it increases. If it increases, what will happen to TIBC? It will go low. And what happens to transferrin saturation? It will also go low. Now you think that why this is going low when ferritin molecule is more? Because transferrin is being secreted by liver, and liver in the anemia of chronic diseases is not secreting transferrin molecules. So overall value of the transferrin molecule is low. That is why the transferrin saturation is low. Okay, so just learn these 2 points before going to the exam. Okay, guys, these 2 things. These are the 2 things, the ferritin value and the total iron binding capacity, which you have to learn before going to the exam, because this is the place where they can ask you the question. Okay, and how to learn that? Ferritin and TIBC, they are inversely proportional. In iron deficiency anemia, नाम में ही iron का deficiency है. So ferritin will be low, so TIBC will be more. And in anemia of chronic diseases, it will be exactly opposite. Learn this way, and no question in your exam would be wrong. Then we move on to difference between multiple myeloma, MGUS, and smoldering myeloma. See, it's very simple. When we are talking about multiple myeloma, we are talking about this, that you will get the plasma cells. It's a disorder of plasma cells. And in the disorder of plasma cells, what we are talking about, plasma cells are something which are making the antibodies. So there is a mutation and the plasma cells become way high. So more than 10% of plasma cells in the bone marrow, it is, plasmacytosis, which is characteristic of multiple myeloma. You can see. Then M protein. Now this is your monoclonal protein which plasma cells, they are making. So it is also being present. And these, these 4 things: CRAB, hypercalcemia, renal failure, anemia, and bone lytic lesions. Okay, this lytic lesion word is very important. Whenever you are having this kind of a word, lytic lesions or punched out lesions, then always look in the options for multiple myeloma. It can be that. So plasma cells ज़्यादा होने चाहिए. So if you are getting this, obviously anything from this and plasma cells more than 10%, so it is multiple myeloma. When you see the smoldering myeloma, beta bone marrow के अंदर plasma cells will be more than 10%, even M protein will be positive, but the crab, it's going to be negative. So if you're getting more plasma, M protein positivity, but crab negative, then it would be smoldering myeloma. And when we are talking about monoclonal gammopathy of undetermined significance, MGUS, then it is, in this, the plasma cells in the bone marrow will be less than 10%. वो 10% से कम ही होंगे, तो टेंशन ही नहीं है. सबसे बड़ी बात तो यही है, less than 10%. क्रैम भी नहीं होगा, and you will have IgM antibodies over there. Okay, so if you're getting more than 10% plasma cells, then there is a comparison between multiple myeloma and smoldering myeloma. But if you're getting less than 10% plasma cells in the bone marrow, it's MGUS. It can't be multiple myeloma. Okay, and what is the most important, most common translocation with multiple myeloma? I hope you remember. It's your translocation 1114. This is the translocation which you have to learn for multiple myeloma. Okay. Then these are the cells which you are getting in multiple myeloma. They might come to you in the image form. So these are plasma cells, eccentric nuclei, one side nuclei. Okay, and this M protein which is getting higher, if it is getting deposited in the nucleus, then you call it as Dutcher cell. If it is this kind of an appearance of deposition of M protein, Mott cell. If it is in the cytoplasm, Russell cell. And if it is at this M protein is giving it like a look of a flame, so this is flame cells. These are your, in the cytoplasm you have Russell cell, then this is your Mott cell, and here, if you see this particular image, inside the nucleus you are having deposition, this is your Dutcher cell. Okay. Then pathophysiology of cirrhosis. Now in this, as we know that in the liver, if we talk about the architecture of the liver, we all know that this is the portal triad on one side, this is the portal triad on one side, and this here is the central vein, and this is how the drainage is happening inside the liver. So, and this portal triad and the central vein, they are connected by sinusoids. What are sinusoids? Which have breaks inside them. So a blood enters from this area like this. Normally what happens is that the blood enters like this, and through the breaking between the sinusoid, it goes to the hepatocytes. Okay, like this. But what happens is, due to continuous injury, when a patient, like for example, a chronic alcoholic, so he is doing continuous injury to the liver parenchyma, and when the continuous injury is happening to the liver, obviously what is happening is these macrophages, they are going to get activated, and these macrophages, they're going to secrete certain molecules like PDGF, like ET1, and they are going to tell to the stellate cells, which are myofibroblasts. So they're going to activate this particular stellate cell, and once the stellate cells are activated, because they are myofibroblasts, so what they are going to do? They are going to lay down collagen. So they lay down a new kind of collagen. This pink line which you are seeing, this is a new kind of collagen. And if you see the black line beneath it, this is your sinusoid actually, which was having a break in the continuity. But now the new collagen which has come, it's a continuous collagen which has come. So your sinusoid is converted into a capillary. So in cirrhosis, the hallmark feature happens to be capillarization of sinusoid. And in this, what happens is that, once this becomes a capillary, now the blood which is entering won't be able to reach to the hepatocyte. This is the line of hepatocyte. This is the line of, so, the blood is not going to reach here. So what will happen to these hepatocytes? These hepatocytes are going to get into hypoxia, ischemia. So what will happen? They will die. So it's an irreversible process. Once this happens, it happens. So your non-continuous collagen is converted into a continuous collagen, making a sinusoid a capillary. This is the hallmark feature, and it's an irreversible process. Liver is permanently damaged in these patients. Okay. Then somebody has asked about I'm taking all the questions which I've got, and then I'll be talking to you in this. See, somebody has told that whether we'll be having the FMGE exam in 2022. I hope that you should not be having this problem right now, because we particularly believe that you would be clearing this exam in the December, but there might be some students who might be seeing this video right now who would be appearing in June 2022 or December 2022. So as per the NBE, they have already said that FMGE 2022 exam is going to be on 4th of June. and FMGE December 2022 exam will be happening on the 17th of December. Okay, so they have already given the dates out, and your NEET PG 2022, which was a hot topic, then when the exam is going to be, it's on 12th of March next year. Okay, so dates have come. So all the people preparing for NEET PG, buckle up. Okay, and some questions were regarding how, Nikhil, you have asked me, so please tell me any tips for neoplasia topic. See, for neoplasia, the important thing happens to be your cell cycle, number one, and second thing, your tumor markers and the stains. These are the two things which are very, very, very important. And third, from that, if you want to learn, you should learn the role of the oncogenes and the tumor suppressor gene. The rest, I don't think so. If the question has to come from neoplasia, these are the things you can learn. I totally understand that, learning these tumor suppressor genes and these oncogenes, which, mutation will lead to which kind of cancer. So it takes a little bit of time, but then, you can write it on a piece of paper and you can stick it to your wall. And when you are moving in the room, or you're going out or coming in, or you are not doing anything, just look at this and try to revise it. So you can learn it that way. Okay. Dikshit, so please tell how to revise medicine. Medicine should be revised as any other subject, and I totally understand that medicine has got a little bit more content over there, because it is an amalgamation of so many subjects together. So we find it a little difficult, but then I particularly feel that if you have done physio, pharma and patho properly, then studying medicine, understanding medicine becomes easy. So, and I really hope that you have studied these three subjects well. So you can do this way, and you can channelize your medicine preparation in a way that the most important unit happens to be cardiovascular system. So start with cardiovascular, then go to CNS, and then endo, and then finally rest everything else. And the session is till 6:30 only. If you've got any other queries, you can put it up here, and we would be happy to listen to all the queries. I would not be taking this session beyond 6:30. It's already 1 minute over, so you can have my WhatsApp number, or you can send it on this number. Your queries you can send on this number. Okay, and if at all, my name is Kunal. You can send on this number, and I would be happy to take your pathology queries, and if it can help you in your exam, it would be amazing. And you all must be having a little bit of fear, a little bit of anxiety right now, who the people who are going to appear on 12th of December exam 2021. Now, just one thing, before I end this session, that you people have done a lot of hard work. I mean, when you came here, when you started preparing for this exam, you ask yourself, you were hugely motivated, but then you had a doubt whether I'll be able to do this much. And there are times, there are days, there are months where you have worked so hard that you were also not expecting this from you. So you've put in a huge efforts to reach to this state. Now this 1 month, the month before the exam, and we all have gone through this, so we understand that this becomes a very, very, very difficult phase, because there are tons and tons of thoughts which are coming in our mind, and feeling that anxiety is, believe me, everyone feels that, so you are not alone. Everyone is having that anxiety, but the better you will tolerate it, the better the result would be. So you don't have to give up. You don't have to give up. You don't have to leave things. You don't have to doubt to the content you are studying, and you don't have to doubt yourself. Whatever you are following, follow that. Do not, go wayward right now, this, that, no, nothing. Whatever you are being following from last 3.5 months, 4 months, follow that for the, full 1 month now. And believe me, on 12th of December, when you're going to give the exam, you all are going to do wonders. And on behalf of the whole team of MIST, I wish you good luck for your exam. And, I'm thankful and happy that you became a part. And thank you, Dr. Princey. Thank you very much. And hope to see you in some next sessions. Thank you very much. Bye-bye.